Jai Hind. Myself, Dr. Shivi will be taking a small lecture on supportive periodontal therapy. Well, before moving to the topic per se, I would like to stress upon two important points. The first one is that this phase of the treatment, that is the supportive periodontal therapy, is as important as the therapy used to treat the patient. Secondly, to prevent the recurrence of the disease. So these two important points we have to keep in mind. So if we look from a periodontal perspective, success of the treatment would mean the long-term goal of the preservation of the teeth following the periodontal therapy as against the short-lived goal of elimination of the disease. The preservation of periodontal health of the treated patient requires as much a positive program as that required for elimination of periodontal disease. So if a person has once developed periodontitis, it has to be assumed that he or she is at risk for future loss of attachment if the bacterial action is not contained in some way. There is at present no definitive periodontal treatment that will cure all the periodontal infections without the residual predisposition to the recurrent infection. And periodontal disease is a result of opportunistic infection by the infective organisms, which cannot be eliminated from the mouth over a prolonged time. And so far, we have no way to boost the patient's immune responses to the extent that these organisms would be innocuous. And the transfer of the patient from active treatment status to maintenance program is a very definitive step in the total patient care, and it requires time as well as effort on the on the part of the dentist and the staff. And the patients should also understand that the purpose of the maintenance program is very important, and the dentist should also emphasize to the patient that the preservation of the teeth depends upon the maintenance therapy. Because we know that if the patients who are not maintained in a supervised recall program subsequent to the active treatment, they show obvious signs of recurrent periodontitis, bone loss, tooth loss, as well as increased pocket depth. So these are the signs of recurrent periodontitis which we should observe when the patient is recalled. The more often the patients present for the recommended supportive periodontal treatment, the less likely that they are it's very less likely that they are to lose the teeth. So that is why it is important for the patients to return back. It has been found out that the long-term preservation of the dentition is closely associated with the frequency and the quality of the recall maintenance. So, when we are treating the patient, it is very, very essential that we inform the patient about what kind of treatment are we carrying out for the patient so that he is compliant, so that he returns back. Because patients who do not return for SPT, they tend to lose 5 to 6 times more teeth than the ones who are compliant. So first and foremost thing is that we should know that the patient has to be turned into a compliant patient. Of course, there are many patients who are not necessarily compliant even after our motivation. But then we have to make sure from our side that we motivate the patient sufficient enough so that he tends to return back. So after having known about in brief of the supportive periodontal therapy, let's know about the origin of the terminology. Periodontal therapy, this term came from Third World Workshop of American Academy of Periodontology in 1989, and this was replaced by a newer term named as periodontal maintenance by American Academy of Periodontology position paper in 2003. Supportive periodontal therapy expresses the essential need for therapeutic measures to support the patient's own efforts to control the periodontal infections and to avoid reinfection. So that is what I was talking about, that the supportive periodontal therapy is basically done to prevent the recurrence of the disease. This phase is carried out immediately after phase 1 therapy so that all the parts of the oral cavity are able to retain the same degree of health that has been attained following phase 1 therapy. Motivational techniques and also reinforcing the importance of the maintenance phase are important steps before performing the definitive periodontal surgery. Because supposingly, if the patient comes to us and we do not inform the patient that these are the treatment modalities which we will be carrying out for him, he will rather be turning into a complaining patient rather than a compliant patient. So definitely it turns out totally meaningless to simply inform the patient that they are to return for the periodic recall visits without clearly explaining them that what is the significance of these visits and also describing what is expected of them in between these visits. Periodontal treatment includes the evaluation of the patient, the cause-related therapy, that is your etiotropic phase. Third is the corrective phase involving the periodontal surgical procedures, followed by the maintenance phase. Now on the left side, you can see the treatment sequence which says that the phase 1 therapy or the etiotropic treatment is followed by re-evaluation, and after the re-evaluation, the second phase follows, which is the phase of periodontal surgery, followed by phase 3 restorative phase, followed by phase 4 maintenance phase. So according to this, the maintenance phase comes at the last, wherein the new concept says that the maintenance phase is actually followed after every phase of the treatment. That is, after doing phase 1, we do the reevaluation and then the patient is put up on the maintenance phase. Also, if the patient is done with the periodontal surgical procedures, then again we have to put the patient on maintenance phase. Similarly, even after phase 3, we are supposed to be putting the patient on the maintenance phase again. So after knowing about the basics of what is SPT, let's get on to know what is the rationale of SPT. The very first rationale for supportive periodontal therapy is incomplete subgingival plaque removal. Now, the incomplete removal of subgingival plaque which might have occurred during the initial phase of our periodontal therapy, it leads to the regrowth of the subgingival plaque. Mark my words, because here only the regrowth of the subgingival plaque is occurring, whereas what we can see, that is the supragingival plaque control, is excellent. So we are not able to visualize the underlying inflammatory response. More so, there is also the slow process of the regrowth of the subgingival plaque, which again emphasizes on the fact that there will be no inflammatory response at the gingival margin when we are seeing the patient during the the supportive periodontal therapy times. So it is very essential that we remove that incomplete removal of the plaque which was done before, so that the continued loss of attachment does not occur. That is why it was rationalized that we should recall the patient after certain amount of time so that we can reevaluate the patient and also do the subgingival treatment of the patient, so that whatever inflammatory responses might have been occurring because of the incomplete plaque removal are totally resolved after the periodontal maintenance therapy. The second point in rationale of supportive periodontal therapy is that the bacteria are present in the gingival tissues, mainly in the aggressive periodontitis cases. Now, whatever bacteria which might have invaded in the intragingival areas, okay, it might be possible that we are not able to remove it during the surgical procedures or scaling or root planing. So what happens is that after the treatment of the patient, when the patient goes back home and he's on the maintenance phase, it might be possible that those left out bacteria might actually recolonize the pocket and cause the recurrence of the disease. So that is why it necessitates that we recall the patient and prevent that recurrence of the disease and prevent that recolonization of the pockets. So the third important point of rationale in supportive periodontal therapy is that there might be bacteria associated with periodontitis which can be transmitted between the spouses and other family members. So that is why even if our patient who was treated successfully initially might return back to you again with the disease, with the recurrence of the disease because of the transmission. So it necessitates the importance of supportive periodontal therapy. Rationale of supportive periodontal therapy is that subgingival scaling alters the microflora of the periodontal pockets. But those alterations can be approximately for 9 to 11 weeks, and it can dramatically vary in between the patients. So it necessitates that we recall the patient, and of course we need to alter that microflora again to a normal one so that the patient is not having the disease again. There's another valid explanation for the recurrence of the periodontal disease is that when we do the surgical therapy, it usually does not heal by the formation of the new connective tissue attachment to the root surface. Rather, it results in the attachment of the gingiva to the tooth surface by the long junctional epithelium. So, That is why the disease might recur. Now, not only the supportive periodontal therapy, that is the mechanical debridement or the treatment which we are giving to the patient during the supportive periodontal therapy visits is important, but also the motivational environment that we are providing to the patient is of utmost importance. These two factors have to be there so that the results of the maintenance therapy are good. And it is the psychology of the patient that when the appointments or when the next appointment of the patient is nearing, he tends to improve his oral hygiene all the more because he knows that his oral hygiene will be evaluated or is going to be evaluated in the near future. And the patient thus performs better oral hygiene in the anticipation of that appointment. And that is called as Hawthorne's effect. So to stress upon this point, there's certainly a very sound scientific basis for recall maintenance because subgingival scaling alters the pocket microflora for variable but relatively long periods. So by doing the supportive periodontal therapy, we are able to achieve the following objectives. That is, we are able to prevent the progression and the recurrence of the periodontal disease. We are able to prevent the loss of the dental implants after clinical stability has been achieved. We are able to reduce the tooth loss by monitoring the dentition and any prosthetic replacements of the natural teeth. We are able to diagnose and manage in a timely manner other diseases or conditions found in the oral cavity. So after we have known that we have treated the patient successfully, now that is the time when we need to put the patients on the maintenance phase. So we need to know that what kind of complexities are present even after the successful treatment of the patient so that accordingly we can classify them patients and those patients then further can be recalled on the basis of the complex factors present in those patients. So this is MERIN'S classification for frequency of the recall interval. But before we classify the patients according to the MERIN'S classification, we need to put every patient under first year patient. So after the successful treatment of the patients for the first year, that is the one complete year, then only we put the patient on for the recall phase, that is your class A patients, class B patients, and class C patients. Now, what is this first year patient? First year patients are the ones in which the initial periodontal therapy is going on. Now, for example, if it's the case of uneventful healing, there is no complexity in the treatment, we can recall those patients for every 3 months for the first year. And secondly, if the patients are having complexities in the processes, are having furcation involvements, are having questionable patient cooperation, so those patients we need to recall at a very smaller interval, that is maybe for every 1 to 2 months we need to recall for the first year. Now, after we have evaluated, we now know the patient's condition accurately and the patient has been treated successfully for the first year, then only we classify those patients into class A, class B or class C category. This is the class A patients which can be characterized by having the excellent results, the ones who are having good oral hygiene, no occlusal problems, no complicated processes. So the main thing is that these kind of patients are recalled after every 6 months to 1 year recall interval. Then this is class B patients which have generally good results. They have maintained well for 1 year or more, but the patient display some of the following characters, not necessarily all. Okay, so these kind of patients are recalled on the 3 to 4 months interval. Then class C patients, which generally had poor results for the first year, and they have one or the several negative factors are present. For example, the occlusal problems can be there, the pockets may be remaining, the processes might be complicated, there might be teeth with less than 50% of the bone support, etc. Okay, so these kind of patients in which lots of complexities are present, these kind of patients are usually recalled at the interval of 1 to 3 months. Now, supposingly, if the patient has an improvement in the periodontal status, has the improvement in the periodontal disease, then that patient can be reclassified into class B patient or class A patient. And if the patient has the relapse of the periodontal status or relapse of the disease again, then what happens is we can again classify them patients into class C patients. So the patients can be jumped into one or the other classification depending upon the present status of the pedonch. Not only the clinical examination, but also there have been recommendations for the radiographs. If the patient is having clinical caries or high risk factor for caries, then we need to take the posterior bite wing radiographs at 12 to 24-month intervals, and if the patient is having no high risk for caries, then it is recommended that we take the posterior bite wing at every 24 to 36 months. Now, these are the recommendations of radiographs for the periodontal disease patients. Now, the first case is if the periodontal disease patients are not under good control, then we need to take the IOPA on or the bite wing of the problem areas every 12 to 24 months and full mouth IOPA for after every 3 to 5 years. And if the patient had history of periodontal disease treatment they are under good control, then we need to take the bite wing every 24 to 36 months and full mouth IOPA have to be taken after every 5 years. And if the patients are having the root form dental implants, then it is recommended that we take the intra-oral periapical radiographs or bite wings after every 6, 12, 36 months after the prosthetic replacement, then after every 36 months unless any clinical problem arises. Now, it is very important for us to know that how we assess the risk of the periodontal patient. Now, it can be used, it can be assessed by using the periodontal risk assessment method. This method is freely available. It's freely available by the Clinical Research Foundation and the University of Bern. And if we go at the site called as periotools.com, you can actually enter the patient's data into the online form which is available, and the program automatically calculates whether whether the patient is at high risk, low risk, or moderate risk. Now, uh, how does it calculate is it takes these factors which have been shown here into this hexagonal diagram. It takes into consideration these factors, that is the pocket depth, the tooth loss, the bleeding on probing, the systemic factors, the environmental factors, and the bone loss divided by the age. Now, all these factors, if supposingly all the parameters, they lie within the low risk category, that is in the green color. Low risk category means within the hexagon, which is green in color, and at least and at maximum only one parameter is lying in the moderate risk parameter, that is in that yellow zone, then we say that the patient is a low periodontal risk patient. So, a moderate periodontal risk patient is if he has at least two parameters in the moderate category, that is in that yellow zone, but at most one parameter lies in the high risk category, that is the red zone. And when we say that the patient is a high periodontal risk patient, we say it if at least two parameters are present in the high risk category, that is in the red zone. So after calculating the risk of the patient, be it the low risk or moderate risk or high risk, what is done is that it estimates the susceptibility of the progression of the disease. So if the patient is at low risk, definitely the susceptibility of the progression of the disease will be low. If the patient is at moderate risk, it will be little higher. Similarly, if the patient is at higher risk, the susceptibility of the patient to progress for the disease is very high. So all these factors should be contemplated and evaluated. A functional assessment of the risk for the disease progression on the subject level, it helps us in customizing the frequency and the content of the SPT visits of the patients. So now that we know what is supportive periodontal therapy and how frequently are we supposed to recall our patients, it is the time that we need to discuss that once the patient has been given appointment for the recall visit, what are we supposed to do on that appointment? So the further discussion will be basically based upon the recall hour or the maintenance program of the patient during that visit. So the periodic recall visits form the foundation of the meaningful long-term prevention program. The interval between the visits is initially set at 3 months but may be varied according to the patient's needs. The recall hour should be planned to meet the individual's needs. It basically consists of 4 different sections which may require various amounts of time during a regularly scheduled visit. Now this is the recall hour shown on the pie chart, in which it has been divided into various sections. The first section is of examination, reevaluation and diagnosis phase, which is for 10 to 15 minutes, which is carried out for 10 to 15 minutes, followed by the motivation and reinstruction for 5 to 7 minutes, followed by instrumentation of scaling, that is your scaling and root planing, for 30 to 40 minutes, which is shown in the yellow color on the pie chart. Then the third section comprises of the TRS, that is the treatment of the reinfected sites. And the last section comprises of polishing, fluoride determination of future SPT, that comprises of 8 minutes. So the recall hour is composed of 10 to 15 minutes of the diagnostic procedures, that is ERD, 30 to 40 minutes of motivation, reinstruction and instrumentation, MRI, during which time the instrumentation is concentrated on the sites diagnosed with So the treatment of the reinfected sites may include small surgical corrections, applications of local drug delivery devices, or just intensive instrumentation under local anesthesia. Such procedures, if judged necessary, may require the additional appointments. Okay. And the last is for 5 to 10 minutes PFD, that is normally concluded. The recall R is normally concluded with polishing of the entire dentition, of the application of fluorides, and other assessment of the situation, uh, including the determination of the future SPT visits. So we have known now how the recall R is divided into various sections, and that is how are we supposed to conduct the appointment of the recall visit. So the important clinical parameters that we are supposed to look at during the SPT visits is the loss of attachment, bleeding on probing, exudate presentation, gingival recession, furcation involvement, or caries, even the open contacts, pose the risk for the disease. So we should clearly, very clearly note down the clinical history. We should note down the loss of the alveolar bone. We should note down the crown root ratio. We should note down if there is any increase in the mobility with the appointments. We should note down if there is any change in the patient's immune system and the response, the effectiveness in the daily removal of the bacterial plaque of the patient, the smoking status of the patient, the root surface smoothness of the patient's mouth, and also the evidence of calculus or root surface accretions. Now, the last section of the lecture comes is the referral of the patients to the periodontist. So when we are talking about the referring of the patients to the specialists, we should have certain points in mind. That first of all is that the general dentist can actually manage most of the cases, because we know that most of the people retain their dentition for lifetime. Second important point to consider is that actually as the proportion of the older individuals increase, definitely more teeth will be at risk for periodontal disease, right? And many studies indicate that there are links between the periodontal disease and the systemic diseases like heart diseases or hypertensive patients or the diabetic patients. So those patients are more prone to develop periodontal disease. So all these things, it makes us necessary that the that we should have a better understanding of periodontal disease, because the prevalence of the patients who require SPT will ultimately increase, because the individuals who are having the periodontal disease is increasing, right? So we should have better understanding of periodontal disease. We should have more expertise over treating such patients. And at the same time, the general dentists hold the responsibility of knowing when to refer the patients to the specialists. Now, the AAP, or the American Academy of Pedontology, have formed certain guidelines for referring the patients to the specialists. Now, if the patients who are having the periodontal disease, which require the surgical procedures on the distal surface of second molars, and maybe the extensive surgical procedures or like osseous surgery procedures or complex regenerative procedures are required, then they should be performed by the specialist or the periodontists. And if supposingly the patient can be handled by minor localized non-surgical therapy or the minor flap procedures, then it can be well handled by the general dentists. So ultimately the general dentists, they have the primary responsibility of referring the patients to the periodontists so that they can be treated at their best, so that the patients are treated, or are given the best treatment. So what factors are we supposed to consider for referring the patients? So the first factor is severity and the location of the periodontal disease. The example I gave you in the last slide. And supposingly the teeth which are having pockets more than 5 millimeter, then it is a case of a borderline. It can be managed by a general dentist as well as a periodontist, depending upon the skill of the general dentist. Or if the if the general dentist is not able to handle, it should be referred to the specialists. And the teeth with the furcation involvement. So we should know if any of these problems are there, especially in a strategically important tooth. Okay, then they should definitely be referred to a specialist for the best treatment. So finally, to conclude, the recall visits are equally important as the treatment visits, and motivational techniques are employed for making the patients willingly accept the visiting the dental office during the recall phase. So for more, you can refer Carranza Clinical Pedontology, 3rd South Asia edition, Chapter 57, Supportive Pedontal Treatment. So after learning about this topic, let's get on to some multiple choice questions. The first question is, patients who do not return for SPT lose dash times more teeth than compliant ones. So what do you think the answer would be? Yes, you're absolutely right. It was explained in the initial slides also that the patients who do not return for supportive periodontal therapy, they lose 5 to 6 times more teeth than the compliant ones. So the answer is D. Now the next question. The next question says, Hawthorne effect is A. Patients tend to improve their oral hygiene in between the appointments. B. Alteration of behavior by the patients due to the awareness of being observed. C. Both of the above. D. None of the above. So yes, the options A and B both are correct. So that is why the right answer would be C, that is both of the above. All right. The next question says, MERIN'S classification is A. Based on risk assessment of the post-treatment patients. B. For the recall maintenance of the post-treatment patients. C. Classifies the patients as class A, B and C patients, or D, all of the above. So as I taught you in the lecture itself, that yes, it is based upon the risk assessment of the post-treatment patients. It is true. It is also true that it is basically meant for the recall maintenance patients of the patients, and also it classifies the patients as A, B and C. So considering all this, I think all the options are correct. So we have the answer as D. Next question. Now the patients who fall under the category of class B patients of MERIN'S classification can be managed by A. The general dentists, B. The specialists, C. Both of the above, D. Self-maintainable patients. Now what do you think the answer would be? Because class B patients are the borderline cases which can be partly managed by the general dentist as well as the specialists. So considering this fact, the answer would be C, that is both of the above. Now, the next question, the amount of the time required for ERD, that is examination, re-evaluation and diagnosis in the recall hour is A, 5 to 7 minutes, B, 10 to 15 minutes, C, 30 to 40 minutes, D, 15 to 20 minutes. So if you remember, I have taught you about the pie chart of the recall hour, and in that the first session was ERD itself, which comprised of examination, re-evaluation and diagnosis. So the length of the time required for this procedure was 10 to 15 minutes. So the answer would be B, 10 to 15 minutes. Thank you very much for your patient listening. So if you have understood everything from the topic which I have taught, it's really good. But then if you have still queries regarding this topic, you can mail me. The email ID is mentioned out here. So stay safe, stay at your homes. Thank you.